From the American Neurological Association, I'm Adeline Goss. This is ANA Investigates. It used to be that the only surgical options for medically refractory epilepsy were big, open, and invasive treatments of last resort. The landscape has changed in recent decades, with more and more minimally invasive surgical approaches being developed. So what does this mean for the average patient with medically refractory epilepsy? Our guest today is Dr. Jon Willie, Director of Stereotactic, Functional, and Epilepsy Neurosurgery at Washington University in St. Louis. He'll speak with Dr. Ionnis Karakis, Epileptologist and Adjunct Professor of Neurology at Emory University, about the new landscape of epilepsy surgery. Here's Ionnis.
Jon, so nice to see you here and to discuss about this very exciting topic.
Ionnis, it's great to see you again. Thanks for having me.
First off, I'd like to ask you about the traditional aspects of epilepsy surgery. We know that open resective surgery has been part of clinical practice for decades now. For our audience members who are not experts in epilepsy, can you please give us a brief overview of the traditional approaches to surgically manage drug-resistant epilepsy?
So talking about our gold standard open surgery for epilepsy, often what people envision is a craniotomy. So after some degree of localization of where the seizures might be coming from, with a series of non-invasive tests and sometimes more invasive tests, and we've determined where we think the seizure onset is, we're making a craniotomy. So that involves usually a patient that's asleep, making an incision of some sort in the scalp, dissecting through the scalp and the muscles, and then creating a window through the bone. We expose the underlying brain and then do one or more approaches that are a very traditional type of approach, such as a temporal lobectomy or something more specific. For instance, a standard temporal lobectomy, probably the most gold standard operation that we do in epilepsy surgery. This operation, depending on how it's done, is usually lasting somewhere around 3 to 5 hours. We often adjunct this with neuronavigation, physiological recordings. These operations can be done awake. For instance, if one is trying to preserve language or testing for language functions, they can be done awake. Usually that means the initial part of the operation is done asleep. You wake up the patient with their pain well controlled, and then you do various types of awake testing while you're doing a resection. And then when you're complete with the operation, sort of in reverse order, you make sure that there's no bleeding. You sew back up the coverings over the brain. You put the bone back in place with little titanium plates and screws. You sew back the muscle, sew back the scalp, and then the patient will typically go to the ICU at least overnight, spend somewhere between 2 to 4 days in the hospital, and then usually we'll go home and then be off of work for a few weeks, follow up in the clinic, wound checks, follow up with neurology. They typically stay on their medications for at least 1 to 2 years. If they've had not any seizures, and at that point, they may start to wean off of some of their seizure medications. That's sort of the big picture of the operation.
Great, thank you so much. Next, I would like to go over with you the minimal invasive treatment modalities for refractory epilepsy, and specifically, I would like you to elaborate on the benefits and the disadvantages of each of them. So let's start with laser interstitial thermal therapy first. We can refer to it as LIT in the interest of time. What does that entail, and how does it change the field of epilepsy treatment?
Yeah, so the good news about the proliferation of these sort of minimally invasive approaches to epilepsy is that it's making more options for patients. So, one thing that we can touch on even before we get to a specific type of approach is that patients often don't want what we have for them. Patients don't want open surgeries. It sounds scary. It looks scary. They can look it up on YouTube or on the internet, and it does not look like something they want. Often the physicians that are first telling them about these approaches aren't that familiar with them themselves. They're often a medicine doctor or a neurologist that may have never even seen these operations. Certainly, these open surgeries carry some risk, either of complications, or even if it's not complicated, there may be some risk that the seizures recur, or there's some sort of neuropsychological or cognitive decline that is scary for the patients. And of course, patients don't like to worry about big incisions. They worry about cosmesis, deformity, pain, discomfort. So the advent of more minimally invasive approaches has really at least provide the potential for offering patients more choices. And so now they can weigh a lot more the risks and the benefits with some of these other things that they care about. So for instance, laser interstitial thermal therapy, or LIT, is an example where we use our traditional stereotactic approaches, that's where we're making very minimal incisions to introduce very small, straight devices along a desired trajectory that's considered safe to a target. And then once there, we're actually using the MRI with a special type of gradient echo imaging that gives us a type of thermometry where we use the MRI as a brain thermometer, and we can image pixels across the planes of imaging we're interested in and look at the temperature change over time while we are delivering this light, which basically generates heat around the probe. And so we literally are targeting and burning a structure from the inside out and using the MRI to guide the safety and the extent of that ablation. So this has advantages. If you're doing an open surgery, you have to cut through healthy brain sometimes more extensively than we'd prefer to get to that deeper structure. These minimally invasive approaches have the advantage that once you've identified where that onset zone is, especially if it's deep, you put a tiny little probe about the size of a pencil lead down into that structure. You burn it from the inside and you withdraw the probe. And so the pass through the brain is very small. The incision is very small. The patient is very comfortable. They, depending on the technique, might go home the same day or the following day. So that can be very attractive to patients. And it can be nearly as effective. The disadvantage is the gold standard is a much bigger operation. And the more brain we take, the greater chance of seizure freedom. But that comes at other costs. What we're increasingly finding out is, it's patients won't necessarily pick the thing that is the most effective every time if it comes at a cost that they don't want. So the patients are increasingly balancing whether they want open surgery versus a minimally invasive approach, recognizing that they might not get the highest rate of seizure freedom off the bat, but that's okay because a lot of these minimally invasive approaches don't burn bridges, and you can always go back and take more brain if for some reason they don't maintain that seizure freedom. So we're learning as we're developing all these techniques. Now that we have multiple tools on our tool belt, we can try to apply the best approach for that individual patient, but recognize that we don't just have one pass at this to make it right. Because in the past, we really only had one chance. You would do this big surgery. You wanted to make them seizure free. You talked them into the fact that there was going to be some neurocognitive risk. You convinced yourself and them that if as long as they stayed seizure free, that after several years, that neurocognition would get better for the most part, and they would be okay. But we learned along the way that that wasn't always the case. And some patients, even long after seizures were gone, were still struggling with the neurocognitive deficits. They might not ever return to work. And so increasingly, we're now informed to be able to help our patients make better decisions about what's the right thing for them. And it depends on the details, right? Is this the non-dominant hemisphere? Is the dominant hemisphere? Is this a lesional case? Is this a non-lesional case? Is the patient's baseline neurocognitive testing suggest that they are completely intact and have a lot to lose? Or does their baseline testing suggest that the part of the brain we want to take out is already quite dysfunctional? All of this can factor into what is the right choice for an individual patient. What's the thing that's going to give them the best chance of seizure freedom with the least downside?
You're making a very good case of this stepwise approach and the use of minimally invasive options in our armamentarium. To play devil's advocate, I can envision a subset of patients who don't give you a second chance, who come to you and they only give you one shot. So let's say that you have a classic mesial temporal lobe epilepsy case of the non-dominant hemisphere, and you have such a patient who will only come to you once in a lifetime. Would you still stick to the new developments, or would you give them their best bet with a traditional temporal lobe?
Yeah, it's a great question. I am faced with this. So even though I am a great fan of the minimally invasive approaches, I still do open standard temporal lobectomies when it's indicated. And so this is a discussion I have with the patient and their situation. We've all been faced with patients where we know that their follow-up may be poor or that they don't have a great deal of social support, and you have to weigh the advantages and disadvantages. Is this somebody who's really going to stick with you, understands that this might be a graded approach and that we can take a stepwise approach, or is this somebody where you really only have one shot? This is actually a big conversation, a struggle with training epilepsy surgeons is if they only learn to do the minimally invasive approaches and don't know how to do the open surgeries, then they won't be able to serve all of their patients.
I agree with you. And one has to factor in also the fact that these minimally invasive approaches are not available in every part of the world. So there are still doctors out there who have only access to traditional approaches. So we may not even have this dilemma at the end of the day.
That is an issue. So these laser approaches, for instance, they're supported by a few companies that make these devices. These companies have a business model. They're selling expendable devices. These things, while they are available in the United States and often many places throughout the world, they aren't available everywhere, although I will say that they are becoming more prolific. But there are alternative strategies using some of these older technologies, such as radiofrequency, which has essentially been around for many decades longer than lit and can be repurposed to treating epilepsy.
Actually gave me a very nice pass to the next minimally invasive approach, which was radiofrequency ablation. How is that done and how does it look like in terms of safety and efficacy?
Yeah, so this is another example of a minimally invasive approach, and there's sort of two flavors of how we do radiofrequency ablation in epilepsy. One is you can use a traditional radiofrequency probe. These are similar to the types of probes that we might pass percutaneously through the skin to treat an inflamed nerve in the spine, to treat pain, or we put through the face to treat the trigeminal nerve for trigeminal neuralgia. We can pass these probes intracranially as well. They're about the same size as some of these lit probes, so about the same diameter of a pencil lead or smaller. And they have thermistors on them. So you put it into a target tissue and you're monitoring the temperature of that tip. Now, the difference between this and lit is you're not doing this in an MRI. You're not necessarily seeing the ablation in real time. However, we have a very empirical relationship, a reliable relationship between the temperature at the tip, the duration of the therapy, and the type of or volume of a brain ablation we're going to get from that. Now, that means I can put this in some areas of the brain where it's safer to do that, and maybe not other areas where I know I'm close to very sensitive structures. Alternatively, the radiofrequency ablation allows me to do things awake. So I could put this in, have the patient awake, and be testing them while I'm doing the ablation because I know that, for instance, if my ablation is close to a language area or close to the motor cortex, I could be ablating until such time as I first start to notice there's a deficit developing and I stop because that's the basically the front of the heat reaching that tissue, making it temporarily dysfunctional. And as soon as I start to run into that, I know I've reached the safety limit of what I can do. I turn it off and they're going to get better. So radiofrequency, although the probes and the ablations individually are quite small, that can be a bug and a feature in the fact that we can apply it safely, and it's a much cheaper form factor than some of these lit devices. So that's the first flavor of radiofrequency ablation where you're using these probes that are made to do that. There's another version which is kind of off-label with any of the devices we have in the United States, but it's been practiced in Europe for decades, which is when we do invasive recording of patients, we put electrodes in their brain in three-dimensional arrays that are piercing from superficial to deep in order to investigate where the seizures are coming from. So often you have something like 10 or a dozen or even 20 arrays going into the brain, and it so happens that your electrodes will often be in the onset zone or very close to it. And it turns out that even though we can't monitor the temperature, we can actually still use our radiofrequency generator, connect to individual contact, and we can generate radiofrequency ablation at those locations with an empirical relationship that's based on wattage and time. And those ablations themselves are a little bit smaller than what we might achieve with those other types of probes, but it can be done in the epilepsy monitoring unit. It can be done awake. We can do it while we're monitoring the patient for seizures or other neurological problems. And so it's a nice way of actually starting the therapeutic process. And while it may not be the most definitive thing because you can only achieve so much, it often gives you a lot of information to tell you if you're on the right track. So an approach like this, where we do radiofrequency through the stereoelectroencephalography electrodes, we kind of refer to it as theragnostic because it gives us diagnostic information, but it also gives us a clue as to whether we're on the right track to understanding the seizure onset zone and if ablating that area is or resecting that area is going to make that patient seizure-free long term. So it's another tool on our tool belt, but applying these radiofrequency approaches, there's almost no downside.
Great. Let's move on to the next minimally invasive approach, which is stereotactic radiosurgery. What is the evidence behind that, and how does it compare to the other minimally invasive approaches that you mentioned and more traditional treatment modalities?
Yeah, so on the face of it, doing radiosurgery for epilepsy seems like a great idea. And in many ways, it is a good idea. What is good about it? Well, we have a lot of experience with stereotactic radiosurgery. We've been doing this for decades, both for functional neurosurgery, I like doing a thalamotomy to treat tremor. We've also been applying it for decades on tumors. So we use this to treat small lesions like metastatic tumors or other focal lesions. So it makes perfect sense to use this on epilepsy. And in fact, there are still places in the world that do this in high volume, such as in France. And the advantage of it, for the most part, is that it is essentially non-invasive in the sense that there's no incisions, there's no poking any sharp things through the brain. So the risk of bleeding is essentially zero. And the risk of infection is zero. So these complications that can come with neurosurgical procedures are zeroed. So what is the downside? Well, a couple things. One, it's still radiation, and sometimes radiation comes with cytotoxic edema or progressive edema and symptoms. And when that happens, there's not a whole lot you can do other than give steroids and wait a while. So that can be scary. Some people are afraid of radiation because of the side effects of it. What's the other downside? It takes a while to work. So as our other procedures, once we do them, they usually work right away. In order to achieve the outcome with radiation, it tends to take longer. And then finally, with the advent of these more minimally invasive surgical approaches, such as LIT, it sort of took the wind out of the sails of doing radiation, because we had this other definitive procedure that was low risk, easy to tolerate, but you could get the benefits of it right away. So the fact is, the data is not bad for radiation, and the neurocognitive outcomes ultimately for it are not bad either. It's just not been widely practiced in the United States because there have been other options that patients are choosing more. But if you go to, say, Marseille, France, for instance, they still do this in high volume. So a lot of it has to do with local practices and preferences.
I see. And how about the new kid on the block, focused ultrasound?
Yeah, so there's a lot of talk and excitement about that. So there is a focused ultrasound device that is FDA approved. That is FDA approved not for epilepsy, however, it's approved for doing thalamotomies for treating tremor. And so the technology sounds exciting. The idea is you use beams of focused ultrasound that go through the skull, and just like, centering a magnifying glass lens on a spot on a paper, if you get that focal length or distance just right, you're going to generate tremendous heat at that one spot. Focused ultrasound is the same way. You send hundreds and hundreds of beams of ultrasound through the skull. Each one of those beams in and of themselves doesn't have much of effect, but where they all meet, they mechanically shake the water molecules and generate heat, and it's quite focal. Just like LIT, you do it in an MRI scanner so you can see where you're generating that heat. So this sounds perfect, right? This should be able to do whatever we want in the brain. The problem is the devices, at least the way they're currently designed and engineered, you only have access to a relatively small area in the deeper parts of the brain around the thalamus and deep brain structures, which is not where most of our epilepsy is coming from. So that has somewhat limited the capacity of us applying this to our most common types of epilepsy. It has been applied to some degree in a few small lesions that are deep in the brain. So, for instance, a hypothalamic hamartoma is a deep lesion that is small. So we just don't have a lot of data right now to tell us what the impact of this is going to be with the technology we currently have available to us. But as I've learned, you never bet against technology. I'm sure we'll have better devices. And while I've talked to you about using focused ultrasound to create ablations, there's also a whole other side of focused ultrasound that is a little bit less destructive. It is meant to do more neuromodulation, where you're actually mechanically disrupting areas of the brain, but only in a very transient way that doesn't burn it, but does cause changes in that brain function temporarily, and that can have therapeutic benefits as well. So I think there's still a lot for us to learn about using focused ultrasound and similar sorts of energy delivery to neuromodulate the brain less destructively.
So, for the epileptologist and other neurologists in our audience, how are these surgeries changing clinical practice in epilepsy? Should more patients be referred to surgical evaluation?
I think, the question is simply, who is a surgical candidate? I think increasingly the answer is, who isn't a surgical candidate, right? So a surgical candidate is somebody who's continued to have seizures despite multiple medications, multiple adequate trials of medications. If you're not achieving seizure control after a few different types of medications, then the epileptologist or the neurologist taking care of the patient should be starting to ask themselves, could this patient be a surgical candidate? And where in the past we used to say, well, a surgical candidate is somebody who has a lesion or is likely to be able to get a type of surgery that is likely to make them completely seizure-free, and those were considered the surgical candidates. Now, increasingly, with the proliferation of our techniques, with better non-invasive and invasive diagnostics, with more minimally invasive approaches, and with more opportunities and better effectiveness of neuromodulation strategies, there's really no category of patient anymore that wouldn't potentially benefit from some sort of surgical or interventional therapy if they're still having seizures despite medications. Not everything is destructive. Not everything is ablative. There are neuromodulation strategies such as DBS, targeting various thalamic circuits. There's neuromodulation with responsive neurostimulators. If we've defined a seizure onset zone, but it's not something that we feel is safe or is likely to make them seizure free, then we can potentially put electrodes in that target and do a closed loop responsive neurostimulator. There's still vagus nerve stimulation. And as I mentioned, there are newer things coming down the bend. So fact is, every patient now that is not having their seizures completely controlled with medications deserves to be considered a possible surgical candidate until proven otherwise, meaning they should be referred to a tertiary center where people specialize in evaluating patients that are medically refractory. They should get some of these basic tests, 3 Tesla MRI scan, interictal PET scan, possibly an ictal SPECT scan, neuropsychometric testing, etc. They might need invasive recording, all in order for us to determine, are they going to be a candidate for something where they could have a potential for cure or greatly ameliorating their seizures, or are they going to be a candidate for neuromodulation, which could help them improve their seizure frequency and severity, even in the situation where we know we don't have a cure for them. So my short answer to who is a surgical candidate is, well, if they're still having seizures, everybody is a surgical candidate until we figure out what they need.
Great. Thank you, Jon, for this very illuminating discussion, for your time and your knowledge that you shared with us. And I will be looking forward to the new developments in the field in the years to come.
Ionnis, it's great talking to you. Thank you.
That was Dr. Jon Willie of Washington University in St. Louis, interviewed by Dr. Ionnis Karakis of Emory University. ANA Investigates is the official podcast of the American Neurological Association. The show's producers are members of the ANA Education Innovation Committee, chaired by Michelle Johansson. I'm Adeline Goss, podcast host and executive producer. Our production team this month included Ionnis Karakis, Jessica Templer, and Jen Hurley. You can listen to past episodes of the show, subscribe to us so you never miss an episode, and access all of the ANA's educational programs on the Education tab at myana.org. That's it for ANA Investigates. See you next month.